Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my immense pleasure to meet my colleague Dr. Abdullah Al Dosary, who is consultant radiologist with subspecialty body imaging. I have a very interesting case, a young patient who had a past personal history of DVT and strong family history of thrombosis, presented with acute abdominal pain and found to have extensive splanchnic vein thrombosis, porto, mesenteric and splenic vein thrombosis. Could you explain to us the finding?
Okay, so this is a CT done with IV contrast on January 22nd, 2018, and it showed a filling defect in the main portal vein extending to the intrahepatic branches of the portal vein. If you follow it down, you'll see it also extending to the splenic vein up to the splenic hilum. And if you follow it more inferiorly, you'll see it extending down to the superior mesenteric vein, extending even to the smaller branches of the superior mesenteric vein. If you look at the fat around the vein and you compare it to the other fat, you'll see there's increased density of this fat. We call this fat stranding or edema. It's probably related to venous congestion, but we have also to consider the possibility of thrombophlebitis in this case. A clinical correlation would probably be able to differentiate between these two entities. Either is it congestion or thrombophlebitis. If you look at the thrombus, it has a high density in some areas, indicating it's acute. There's no obvious collaterals around it, which is against a chronic thrombus. So it's most likely an acute to subacute thrombus. The patient has mild splenomegaly. Look at the spleen, it's about 13.7 centimeters. Normal spleen should not exceed.
So borderline splenomegaly.
It's mild splenomegaly, we call
Okay.
it.
Dr. Abdullah, what are the signs of chronic portal vein thrombosis?
Signs of chronic portal vein thrombosis is attenuated portal vein. Sometimes you can see calcification in the thrombus, and you see also collateral formation around the thrombosed vessels. Signs of portal hypertension in the form of splenomegaly, orthosystemic collaterals, sometimes ascites, edema in the bowel wall. These are also signs of
Recanalization?
It can happen sometimes, recanalization, and it goes back to normal. You don't see any collaterals at all. Sometimes the recanalization is partial, not complete. And sometimes I've seen cases where the portal vein goes back to normal. You wouldn't know that the patient had previous thrombosis.
Excellent. Dr. Abdullah, how to make sure that the patient have bowel ischemia or not?
Well, in venous ischemia, it's not as easy as arterial ischemia. Venous ischemia, usually there's severe thickening of the bowel. In advanced cases, you see lack of enhancement in the bowel wall, and sometimes pneumatosis intestinalis, which is gas in the bowel wall. These are advanced cases. In early ischemia, we cannot differentiate it just from edema. It's just edema, and most of the time the thickening in the bowel is related to edema and not related to ischemia.
Can you see in this patient the finding?
If you look at the coronal images here, I'll show you. Here's the normal small bowel loops and the distal small bowel in the right lower quadrant. If you compare it to the bowel loops in the left upper quadrant, you see there's some thickening in the left upper quadrant bowel loops. These are the jejunal loops. This is probably just due to edema, from venous congestion. Just like when you have DVT, you have swelling in your limb.
Sure.
When you have also DVT, the splanchnic veins, you'll have thickening and edema of the drain organs.
And the air, that one, is it really inside the bowel or inside the lumen?
You can see it here. This is in this area, for example. You can see the wall around it, and the gas is within the lumen. In this area also, the gas is within the lumen. If you see the gas more peripheral, and usually it looks like a string of beads, then you worry about pneumatosis intestinalis.
Excellent, because very important, as you mentioned, clinical correlation, because there is discrepancy between the clinical and radiological finding, and surgical consultation is mandatory to evaluate the patient. When do you recommend to repeat CT abdomen?
It depends on the clinical manifestation. Sometimes if the patient is doing well and you want to follow, you don't need to do a CT, you can do an ultrasound.
So clinical surveillance.
Yeah, of course. It's much. It depends on your. If the patient is not responding clinically or has persistent symptoms, then you can repeat CT at any time.
Otherwise, just one CT abdomen is enough.
One CT abdomen followed up by ultrasound if the thrombosis is can be seen by ultrasound. If it's in the deep veins, retroperitoneal veins, or in the mesenteric veins, then maybe a CT or MRI if you want to avoid radiation. You can do an MRV or a routine MRI to look at the deep veins.
Yeah.
And you can also see in this patient he has small amount of ascites, which is related to portal hypertension. He has an old thrombus in the left external iliac vein. Look at the right. On the right side, he has the normal right external iliac vein, and on the left, you can see the small iliac vein with the focus of calcification, indicating chronicity. And another sign of chronicity is also the presence of these collaterals.
Excellent. Dr. Abdullah, is it adequate to perform ultrasound abdomen to diagnose subclavian vein thrombosis, or need CT? So what advantage of CT over ultrasound?
Ultrasound, the advantage of ultrasound is portability. You can do it bedside in the ER without sending the patient. Also, you can do it in patients who have abnormal renal profile and you cannot give IV contrast. But of course, CT is much more sensitive for, at least for the deeper veins in the mesentery and the retroperitoneum. Ultrasound is obscured by the bowel gas, so you wouldn't be able to see the smaller veins or the deep retroperitoneal veins. So that's the benefit of CT.
It's not good to assess the bowel for bowel ischemia, the ultrasound.
Of course, yes. You need, if it's very advanced, sometimes you can pick it up in ultrasound, but of course CT is much more sensitive and specific for bowel ischemia.
Thank you, Dr. Abdullah. Just to summarize the case, the finding.
Finally, this patient has signs of acute and chronic thrombosis. The chronic thrombosis is in the left external iliac vein. Manifested by retracted vein with calcification and the presence of collaterals, subcutaneous collaterals here. And he has also signs of acute thrombosis in the form of portal vein, splenic vein, and superior mesenteric vein thrombosis, with signs of edema in the bowel wall, ascites, and mass splenomegaly. So this patient needs to be investigated well to see what's the cause of these recurrent episodes of thrombosis.
Yeah, thrombophilia workup. Thank you, Dr. Abdullah, for enlightening us about this case.
My pleasure.
Okay.